Good afternoon, everyone. My name is Sarah Fuchs, and I'm a senior specialist for the Community Education Department at MDA. We're thrilled to have you join us for today's webinar on updates in Friedreich's ataxia. This learning event is part of our larger MDA community education programs, which focus on bringing the neuromuscular disease community together around education and resources. Be sure to visit the community education section on mda.org for updates on upcoming events. We are recording today's event and will be posting it to the website for on-demand viewing at a later date. Everyone registered for today's session will receive that information in their inbox when it's posted. Please know that all phone lines have been muted, but you can still ask questions. And we encourage you to ask questions. We'll have a Q&A session at the end of our speaker's presentation. So simply use the chat feature, which should be at the bottom of your screen, and type in your questions as they come up, and we'll address those at the end. I do want to extend a special thanks to Biogen for supporting today's program. And for nearly 75 years, MDA has led the way in funding research to accelerate the development of new treatments, expanding access to care and clinical trials through the MDA Care Center Network, and advocating for access and inclusion for the neuromuscular disease community. MDA delivers its mission through research, access to care, advocacy, education, recreation, and engagement. Since its inception, MDA has invested more than $1.1 billion in neuromuscular disease research. Our MDA care centers are located at over 150 top medical institutions nationwide, providing care from clinicians who specialize in neuromuscular disease. MDA's advocacy work focuses on support for accelerated approvals and novel research, access to healthcare, accessible air travel, and more. This focus plays a vital role in shaping laws and policies that support the needs of people living with rare neuromuscular disease. Our community education and recreation programs are designed to connect individuals and families. We are committed to building a nurturing environment where our members can share experiences, triumphs, and challenges. Every year, we offer over 40 educational programs, over 20 summer camps, and dozens of other community activities, both in person and virtually. If you haven't done so already, we invite you to join the MDA community by registering with us. Registering is free. Please see the link in the chat for more information. Now it is my pleasure to introduce today's speaker, Dr. Elena Caron. Dr. Caron is a neurologist in Memphis, Tennessee, and has over 13 years of experience in the medical field. She graduated from the University of Alabama at Birmingham in 2010, and Dr. Caron practices both general pediatric neurology and neuromuscular medicine. She is an associate professor of pediatric neurology at Bonheur Children's Hospital since 2014 and has worked at the MDA Care Center at that location since 2010. In 2019, she assumed the position of MDA Care Center Director and continues in that role to this day. Dr. Caron, thank you for being here today, and I will turn the time over to you.
Thank you. Okay. Good afternoon, everyone, and it is really an honor to be asked to talk about such to the Friedreich's community. Thank you, MDA, for asking me, and thank you all for participating. It's obviously whenever you give a talk, you do a lot of reading to try to make sure you're up to date on everything. So it helps us learn to dive into topics more. Friedreich's is a rare disease, so although we have patients in our clinic with Friedreich ataxia, I'm like everyone else. It's rare, and we really have to keep up because it's hard. We don't have the volume we have in other patient populations. So thank you for coming together this afternoon. I just want to Hopefully this talk is relevant and helpful to folks. I think the most important thing is I'm not an expert in Friedreich ataxia. I do treat people with Friedreich ataxia, and I've studied neuromuscular medicine for years, but there are amazing experts and people studying this, doing wonderful investigations, and that's the literature I wanted to bring today. So I'm more of a vehicle of this great work that other scientists have done through care guidelines. So I'm gonna, let's see if I can make this move forward. Maybe I just do that. There we go. So the agenda is going to be starting with genetics and then go through pathophysiology and clinical, then expert recommendations. You know, those were published in 2022, and then treatments that are FDA approved and what's in the pipeline. And then we can have discussion if time allows, but hopefully it will. And as Sarah said, please send things in the chat box. I don't mind to be interrupted. I think it's good. If you have a correction or something you'd like to bring up, please do. I'm happy to be interrupted. So for prevalence, I think it is interesting how rare this disease is. It's 1 in every 50,000 to 100,000 people in the USA, and 1 in every 29,000 individuals of Caucasian ancestry, which I think is really interesting worldwide. So it's not like others that the, your race or ethnicity would determines in some way about Friedreich's risk. The most commonly inherited autosomal recessive ataxia is Friedreich ataxia. So that's why it's important when people have ataxia that we at least are thinking of this. Onset is between 5 and 20 years old. I think that's also difficult. It's such a wide range of onset. Typically, it's around age 10. So most people present around that age, but it can be late onset. So we as clinicians need to be thinking about people with late onset ataxia to test for this. The typical genetic mutation is a homozygous, meaning a copy from your mom, copy from your dad, has in the FXN allele as a trinucleotide repeat expansion in this intron 1. Normal alleles in the FXN gene have less than 33 repeats. But as you can see off to the side, people with 66 to 50 repeats, they will be symptomatic of Friedreich's, and that's the majority of people. And then 4% will have a point mutation on one allele and then a deletion on the other. But most people have this homozygous expansion in both alleles. So I just misspoke. The small percentage, 4% of people will have a point mutation or a deletion, and then the other gene is expanded. So that trinucleotide repeat just disrupts the way that FXN, the frataxin, is produced, which is a protein we really need. And the more repeats, the more poorly it's reproduced. So people will have the longer repeats, people will usually say that predicts the age of onset, rate of progression of disease, and how much residual frataxin you'll have. So the longest repeat is the worst. So what predicts how you'll do is that shorter repeat, because that's the one that will produce what frataxin it can. And I know that's a kind of a tough concept, the genetics and the way this works. So maybe that's something we'll just have to go back through or read about. This is what it means when people have a homozygous recessive inheritance. And I took this off of the FARA website, which is an excellent resource, as you all know. That means that you have to receive a copy from your dad, a copy from your mom, and you as a child would have a 1 in 4 chance with each pregnancy to pass a homozygous recessive disorder. So as you can see, one child is affected, one child is a carrier, 2 children would be carriers, and then 1 would be unaffected. But with each pregnancy in the same couple, if they're both carriers, you would have a 1/4 chance of having a child affected with Friedreich's. The pathophysiology of frataxin is a nuclear encoded protein for mitochondria. And mitochondria, as you may or may not know, are what helps us supply energy to our cells. And this the mitochondria, iron metabolism and iron homeostasis is reached. So the good metabolism of iron, the levels of iron being normal, are managed by frataxin. It also puts together these iron sulfur clusters, which are involved in our energy production in our body, and things you probably remember from science classes like ATP and the Krebs cycle. So, any energy process, if you need a certain protein to make that energy cycle efficient and work, that's what we're missing with Friedreich's. And it's a variety of cells that are affected. So there is this oxidative stress that occurs when you don't metabolize things well or don't get the energy production. And the cells that are most affected are those that are large sensory neurons. So the dorsal root ganglia, that in itself can cause some imbalance. The dentate nucleus of the cerebellum, upper motor neurons, which make spasticity part of the disease, and then the cardiac cells and pancreatic cells, which we all know that aside from neurologic complications, there are cardiac and endocrine complications of Friedreich. So the neurologic features that we typically see are progressive ataxia. That's usually what brings people to the clinic. And then spasticity, because all of that will affect your balance and mobility. So people typically come with those complaints. But the unusual thing is they'll have absent reflexes because of that sensory neuropathy. And that's unusual because usually with spasticity, we see increased reflexes. So with that, we usually have a little more concern that this could be Friedreich ataxia, but also visual and hearing dysfunction is important to remember. Non-neurologic features are scoliosis, foot deformity, the cardiac disease and endocrine disease, and mental health issues. So we don't have a pharmacologic treatment for ataxia. However, some therapies can be helpful, as well as preserved vision and hearing. As you know, other senses can help you reduce your imbalance when you have ataxia if you are able to see. That brings us to the point that with Friedreich ataxia, people do have impairment in their some vision functions, such as these abnormalities to the optic nerve and how it carries signals, impaired spatial perception, and visual field abnormalities. This is due to a progressive optic neuropathy. The optic nerve is actually having some impairment, but it can be a slow progressive or rapid. So it's important, honestly, just to make sure we're watching people's vision and then giving assistance where that's needed. The optic neuropathy usually correlates with the repeat length. If that is longer, people have optic neuropathy. Hearing is also something that can be impaired in people with Friedreich ataxia. Usually it says with a repeat length of greater than 500 increases the auditory and spatial processing difficulty. So it's nice to know that with certain repeats, you need to be watching that. And with 90% of people with Friedreich's, and they will have difficulty understanding speech when there is background noise and impairments in selective attention. So that's important for us as doctors or people who interact with people with Friedreich ataxia to remember what is the best listening environment. Further down on this, I won't go through everything. Some of these slides are busy, but I wanted to at least present the information from these great resources. Only about 50% of people were able to, well, sorry, that's not what it was. It was people with Friedrich's, when they're listening, they can only access about 50% of the information being said. So that tells us we really need to be aware of this speech and communication, where people need to be sitting, what environment we need to be talking to them in. So cardiac is another area of important monitoring. Dysfunction leads to a cause of death, accounting for about 60% of mortality in people with Friedrich's. Most show a cardiac abnormality on the EKG. Arrhythmias, particularly atrial arrhythmias, are common. And heart failure is a major cause of morbidity. It can be complicated to monitor for cardiomyopathy symptoms, because people sometimes, if they're not as active, they may be more sedentary, they may not feel symptoms as much. But when they have emergency situations where they need IV fluids, or they're vomiting, getting dehydrated, their cardiac symptoms become more acute. So it's very important to be aware of that as part of their emergency symptoms. Orthopedics, there is a risk of scoliosis, and typically people who have a onset of disease after 14 years of age, it's typically mild, but earlier onset, you need to be watching more closely. The foot deformity we talked about is called pes cavus. That's with a high arch in the foot. Doesn't really flatten when you put pressure or stand up. The foot has a very high arch and maintains it. And that can play some role in the functionality of the foot and stability of the foot ankle. Endocrine complications, again, because we were talking about these high metabolic areas or cells in the body that mitochondria will need to function very well. So if you have a high metabolic demand, such as the muscle, the heart, the eyes, those tissues are affected early, and the pancreas is one of those. So people with Friedreich, if they have early onset, like they'll have typically a type 1 diabetes and require insulin. But if it's later and they have other factors such as obesity, then perhaps that might be a type 2. And that, depending, you'll type 1 or type 2, that will kind of let you know what the medical treatment would be. But it is something that needs to be watched for, especially if people are losing weight, feeling sick, not doing well. Checking a hemoglobin is important, a hemoglobin A1C. Bone density is another part of risk factors we need to be watching for. So osteoporosis. They think that there are just multiple risk factors for developing low bone density in Friedreich ataxia because of mobility issues. So maybe they don't reach their peak bone mass as children and then develop osteoporosis as adults. They did not see a difference in the calcium that people with Friedreich ataxia versus healthy controls. So there may be issues with mobility, other things like that that are affecting the bone growth and bone density, such as using a wheelchair early on, things like that. Supplements, dietary supplements, or just getting the correct dietary allowance didn't seem to be met by more than 50% of adults. But supplementation, about 60 to 60.5% of people are using. So it is important to make sure we're making people aware of what are the nutrients people need to develop good bone density. Some of these things are just very important. Urinary dysfunction is a very important issue for people who have this sense of urgency, and that seems to be something reported commonly in Friedrich's. They may not have true incontinence, but they feel a sense of urgency. And it is probably due to some of the neuronal innervation of the bladder or parasympathetic nervous system being affected due to Friedrich's ataxia. But we don't have a specific understanding. but anticholinergic therapy. And you can think of some medicines like ditropan or Ditrol that are used more commonly for urgency or spastic bladder. Although not curative, they are helpful, and that is something that can be very disruptive to people. Depression and mental illness are also topics that need to be addressed. So I'm talking mainly to myself while I go through this talk, but also educating folks that it's important to bring this up to your people you talk to, either your family, healthcare providers, or counselors. And it seems to be under-recognized because 92% of people with Friedreich ataxia will report symptoms of depression, which affect their quality of life. This is another area that we don't know if it's endogenous kind of disease related to Friedreich's, or is it a reaction to the disease-specific events? And there is not a specific therapy for people with Friedreich ataxia with depression, but what I'm reading is that it is important to use medications if that is appropriate, such as selective serotonin uptake re-inhibitors, and pursue counseling. So it's important to treat people with Friedreich's with depression or anxiety just as you would other people, and look into all of the modes of therapy that you would treat anyone else. So expert recommendations are very helpful, and some reasons, so I'm kind of moving out of the clinical and genetic part and moving into kind of specifics about Friedreich ataxia and guidelines that people have come up with that are very helpful for all of us to use and know. So I titled this slide, "The Complexity of Rare Disease and Recommendations or Guidelines," because they made good points in this article about it's a rare condition. It's often difficult to access experienced people because, like I said, I call myself a neuromuscular specialist, but I've only had 3 people in my clinic with Friedreich ataxia over the past 10 years because it is rare. So yes, we're learning, we're reading the literature, but it is often hard to make sure that the PTs, the speech therapists, all of our team is up to date on Friedreich ataxia. So that can be a challenge for all of us. It does have, for that reason that it's rare, it can be hard to get these adequately powered studies that tell us, yes, if we do this, this is an intervention that is good for the long term for people with Friedreich ataxia, or this is not. So we don't have that certainty because we can't get enough people in studies to understand that clearly. But what we can do is develop these recommendations and guidelines, which this group has done, which is excellent. So I think it just presents a lot of issues when it's a rare disease, and that's why it's important to have talks like this and stay up to date and have more literature coming out. Finally, there is at present no approved therapy that significantly alters the symptomology or the progression. So we do need to just all as people involved in the Friedreich's community understand what it is that affects quality of life and how can we do our best in preventive care and also quality of life care and support, and be very knowledgeable about that. So the current guidelines were created by 39 experts around the world. Each is designated a grading A through D. And what we really want to know is if it's a grade A, it's reliably to guide our practice. And grade D, it's signified as weak evidence and take caution when you apply it to someone. So I think those are the most important ones. B and C are such in the middle ground, you have to use judgment. And cases where it was unable to give a graded level to a recommendation, then they just made these best recommendations or best practice points. So I wanted to go through some of these that I thought were relevant and important to talk about or highlight. Obviously, I'm not just going to read these slides. I think that's very boring, and I'm sure you do too. But the neurologic symptoms are what we all want to know. What can we be doing to improve or be watchful, monitoring, and preventive? So for the upper limb function, ataxia can and spasticity can be very disruptive. And you want to do an annual comprehensive assessment of upper limb function by the multidisciplinary team, including PT and OT. So if you look down at these recommendations, there is nothing that's very strong. They say conditionally, cannot recommend. And I think that's helpful because then you yourself can look at that and say, well, it it looks like there's not a lot that I have to do, but I do think that having the annual assessment is important. It also does say they recommend against the use of pharmacologic agents for specific management of upper limb function. So, um, need to really think about it before you use pharmacological management. Um, then the other very important topic after upper limb is strength and balance and mobility. That's really important. So recommendations um, for people who are ambulant to have regular monitoring and physical and non-physical factors for mobility decline. So looking at things like what about your balance, your strength, at least once a year evaluating that. And looking at a multifaceted rehab approach, targeting multiple areas. So, as you know, when people just say, oh, you just need AFOs or you just need a cane, that's probably not going to answer everything because there's more to it. There's a sensory neuropathy, there's ataxia, and there's spasticity. So, we have to be a group and talk to our PTs and OTs and see what's working for you. And so I think the best approach is these yearly evaluations, but also multifaceted. Look at all the ideas and what works for you. Um, let's see. This is another one on strength and balance and mobility. I didn't have anything highlighted here, so I won't delve into that too much. But um, there is this statement. I think it's important to pay attention when they say we cannot recommend either botulinum toxin or other injections for ambulant individuals with ataxia with ankle or foot spasticity. So, they weren't able to recommend that completely. Certainly, you have to take people on an individual basis to know, is this one thing going to help or should we try it? But I think it's important to pay attention when they say they can't wholly recommend it. Let's see. I think this second part is really important. I think we all know as adults, it's not one muscle. It's not like, oh, I just need my abs to be stronger. And the same goes for all adults. Even people with Friedreich ataxia, we need to have good strength and to have good stability in the hip girdle. And so finding ways that you can develop core strength, hip girdle, paraspinal, ankle mobility, all of those things, can you incorporate that into your exercise and rehab so that you can have better long-term ambulation and safer? Okay. I had some others that I highlighted that I want to get to, so I'm going to move on to this one. So there's information about spasticity. As you know, the corticospinal tracts are affected in Friedreich ataxia. That leads to spasticity and pain and spasms. Spasticity can be affected by whatever condition. If the person is tired, hungry, dehydrated, stressed, or in pain, sick with something else, spasticity will get worse. So I think that's important to remember. If you're feeling worse and you're tired, not getting enough sleep, not getting enough nutrition, can't drink enough fluid, some things can affect your spasticity and make other neurologic symptoms worse. So it's important to remember that, try to treat those things, and it may improve your spasticity or your neurologic symptoms. And then, as we were talking about, use of baclofen or Botox, if you are using anti-spasticity interventions, you also want to evaluate people, not just say, take this medicine and see you in 6 months or 3 months. You want to see, well, did that make something weaker that was actually functional? And now we took away some of your function. So it's fine to try certain things, but it's always very important for the person who's seeing you to reevaluate what that did, because sometimes you need your spasticity to make your strength for standing or doing certain function. I thought this was an interesting one, and I've had some of my own patients talk about this, the dysarthria and the speech issues. And what I thought was most interesting is that they said interventions to improve the communication skills should actually be focused on the listener. So I think we can all take a lesson from that. Me as a doctor, family members, people who support people with Friedreich ataxia. Um, and that's important for people to know. So maybe what we need to do is be focused when we're having conversations with people with Friedreich ataxia, be in a quiet setting, identify strategies that don't allow, that help reduce barriers to understanding each other. So that was very informative to me. And I think that's just very, very telling that, we as people who want to interact with people with Friedreich ataxia need to be the people making the biggest adjustment there. Speech therapy, there are different targeted therapies that may be helpful. They have this targeted intensive behavioral therapy for improving speech. That was a recommendation. They couldn't recommend an AAC treatment. And then pharmaceutical therapies are not used to treat the dysarthria. Pulmonary function. These are very important questions to ask and discuss during appointments or think about on your own. How is your sleep? How do you feel when you wake up? How are you sleep? Are you napping during the day? How have you been doing? Because our breathing during sleep typically translates into how our mood, our learning, and our alertness during the day. So if you are having some of those symptoms, it's important to think about, or if you know someone with those symptoms, bringing up sleep disordered breathing or pulmonary function is important. So most people will have pulmonary function testing at their clinic. That would include, the testing with the pulmonary respiratory therapist. And if there is some decline in function, you may need certain airway clearance techniques or non-invasive assisted ventilation. So that should be measured. Depression, we'll touch back on that. I kind of went through this, but it's important to regularly think about how people's mental health is going, and know that offering counseling, thinking about counseling, and is important as well. Some people have said, well, it's just a transition right now. This is a rough time. But what we don't want to do is delay addressing symptoms of depression and address them the way you would for anyone with signs of depression. Anxiety is similar. Counseling, they recommend counseling over therapy, over no counseling. So certainly counseling is something that should be addressed. And they say, don't just say lifestyle changes. They want to actually treat the anxiety so that people can continue to certainly pursue life functions that they would like to do. So counseling and medications always before lifestyle changes. Emergency presentations, I think, is a very important part I wanted to include in this, because so many times it's rare in our clinic to see people with Friedreich ataxia. Like I said, we've only had about 3 people in 10 years. So that's very rare. So for an emergency department, it's even more rare. They're just general medicine. So I think it's really important to have emergency cards. What are things that people need to know when I go to the ER so that they don't have to guess, and I know that they can focus in on things quickly. One of those is chest pain in Friedreich ataxia. So coronary artery disease is not more or less common in Friedreich ataxia. So it certainly could be something to think about. But the EKG is usually abnormal in Friedreich ataxia, um, but that can be in the absence of coronary artery disease. Troponins can be elevated in patients with Friedreich ataxia, even if they don't have coronary artery disease. So it's important for people to know that, maybe for other reasons. If the troponin is elevated, that's something people look at as a marker, a blood test to see how the cardiac function is going. And um, certainly people with an enlarged heart, cardiomyopathy, are at risk for angina-like pain. So having some recommendations from your cardiologist that are just written in your note that you could quickly, show to people in an ER is always helpful to people in a time of distress. Musculoskeletal presentations, pain due to spasticity or spasms can certainly um, impact physical function and mobility. Sometimes people need treatment for that. And you don't want to have to go to the ER for that all the time, but that's something that you want to think about. Urinary tract infections certainly can be an issue. They can also make the spasticity worse. Some people are using self-catheterization techniques, and that would need to be reviewed. Bladder scanning, KUB. So, the standard of care, if somebody has a UTI, you want them to have the same workup anyone else would have. And sometimes when people have a specific diagnosis with Friedreich's, uh, instead of just moving forward with the typical workup you would do with anyone else, it seems a little scary. So that's why it's nice to let people know what your kind of care plan is. And I think that's good to ask for. As I was saying, people are at risk for diabetes with Friedreich ataxia. So routine diabetes screening is important, especially if someone is sick. Perhaps that is complicating their illness, or that is the reason for their illness. So that's an important thing to remember is one of the complications of Friedreich's ataxia. Finally, advanced care planning is also in the guideline. That's one of the best practice statements. And they say, given these advances in medical technology that we have to prolong life in the setting of advanced disease, all adults with Friedreich ataxia should consider appointing a designated healthcare representative. And that's typically somebody, a trusted family member, close friend, independent advocate, someone who understands you, knows what you would like or what you would not wish to have. So that's important for any adult, but I think it's just important to think about. Finally, the exciting topic of treatments. So this is taken from the FARA website. I'm sure you're familiar with Friedreich Ataxia Research Alliance, which is an excellent resource. And they outline here across the top, where are they in the stage of development? And then down the left side, where are we focusing the treatment? So in this first group of 4, it's to improve mitochondrial function and reduce oxidative stress. And that's the approved drug by Biogen called OMAV is what people call it for short, an NRF2 activator. And there are 3 other drugs. One is in phase 3. You have modulation of frataxin metabolic pathways. That's in phase 2. Frataxin replacement or stabilizers. That's in phase 2. Then you have increase the gene expression. That's in preclinical, so in animal studies, and ex vivo cell therapy, and then gene replacement and gene editing. So those are earlier phase, but they are in progress. So I'll take a minute to talk about omaveloxolone or OMAV. And the background is that frataxin, we talked about the gene that has this triplet repeat, so it can't be transcribed to get normal frataxin. So when you have a deficiency, it causes dysregulation and antioxidant defenses. So, oxidation puts stress on our cells. And when it does that, the cell doesn't function well, and then the cell can die or be injured. So you need something to regulate, these antioxidants. And so that can contribute to mitochondrial dysfunction. So if you don't have antioxidant defenses, then your mitochondria don't function well. And that impairs NRF2 and ATP, which we all know is cell energy. So in the healthy state, oxidative stress causes NRF2 translocation to the nucleus. It goes in the nucleus, increases expression of antioxidants, and it protects cells. But in FA, both the mitochondria function and the NRF2 signaling are dysregulated. So in first tested in these cultured cells with patients with Friedreich ataxia, they exhibit a hypersensitivity to oxidative insults, likely due to NRF2 signaling and decreases in NRF2 mediated endogenous antioxidants. So you just don't have that protection. When fibroblasts from FA patients are challenged with agents that induce oxidative stress, NRF fails to activate, so you don't get that protection of antioxidant from NRF2 target genes. And because the nervous system is sensitive to changes in cellular redox status, impairment of that NRF2 activation may contribute to the neurodegeneration in FA. So in OMAV and related analogs are among the most potent known activators. So treatment with OMAV and in vitro restores mitochondrial function and fibroblasts from FA patients and in neurons from FA mouse models. So the study, which was reported in 2021 in Annals of Neurology, there was the treatment with OMAV significantly improved neurologic function relative to placebo after 48 weeks of treatment. Patients treated with placebo had mFARS scores which worsened. Patients with omaveloxolone had improvements in neurologic function after 48 weeks, not only in the primary analyses, but in post hoc analyses. So I'll show you some graphs from that original article. And you can see this is on the far left graph is the mFARS scale. And on the right is the upright stability score. And people were blinded and people tested people after they had been all these intervals. And how did they score in their mFARS and on their upright stability? And you can see those in the black line, which is OMAV, and those that are placebo, they had an increase in their mFARS score, which is not a good thing. And those on OMAV had a decrease, and their upright stability subscore also was more stable, those on OMAV than those who weren't. The common adverse events are headache, nausea. Some people have an elevated ALT and AST, fatigue, diarrhea, and abdominal pain. So those are things to look out for, and obviously lab tests are needed before and during this medication if people start it. So I'm going to take a little break there because I've been kind of talking constantly. I don't know if there are questions or things people would want to talk about at this point.
Thanks so much. Do you want me to take over and then I can put it on my Q&A screen over here and we'll start with some questions?
Sure, that's fine. I did
Alrighty.
have a patient of mine offered some of their own challenges and things they thought about. We can talk about that after if there's time.
Okay, let's get into some questions. I see that we had a couple that were submitted during the presentation, so we will start with those. The first question is there any trial and research going on in any country for the hereditary genetic disease Friedreich ataxia? If yes, then which company is doing it, and what is the name of the medicine, and how much time will this medicine be available for patients of Friedreich ataxia?
So read the first part again for me.
First part is there any trial and research going on in any country for hereditary Friedreich ataxia?
That slide I pointed out, yeah, you could probably go back to it, or I could, but I think the best resource for that, there are two resources. One is clinicaltrials.gov. They have all of those trials that are in phase 2 or 3. That means that those are trials that are ongoing. Now, the question would be, you want to look on clinicaltrials.gov, or I think the FARA website has links to different trials that are ongoing. And you could look and see, is this available for, what my mutations are, my genetics? Is it that may be specific age ranges? And there's always eligibility criteria and ineligibility. So you want to look at both of those things and then see at the lower, as you go down in clinicaltrials.gov, it'll say centers, and you can click on that and it'll tell you what countries are offering it. So there are probably a lot of studies going on. I think one of the very important things is to get in the Friedreich ataxia registry, which is important to join, because then you will get very updated information. So if you participate in the Friedreich ataxia registry through FARA, through their Friedreich ataxia alliance, then you will have your information there, and they can contact you when studies that you're eligible for are coming up.
Oh, that's great. Thank you for sharing. My colleague Jessica did put MDA's clinical trial finder tool into the chat if
Wonderful.
you'd like to check that
Yes,
out. Dr. Caron, I also wanted to let you know, you mentioned the ER summary. We also linked an MDA resource for
that's fantastic.
an ER
Okay.
summary that you fill out yourself. It is a general neuromuscular card, but you fill out any relevant information, keep it in your wallet, and hopefully that hopefully you won't
Yeah.
need to use it, but if you need it, it's there.
Right. And you
Um,
always want to, it's, you could even bring that card, the MDA card, to your appointment and have cardiology put their one liner, have pulmonary put their one liner, neurology. And then you have a person's name attached to it also. So when you go to the ER, people know who to call.
that's a great idea. We did have a question submitted upon registration, which kind of related to the last question about clinical trials. Do you know if typically, if somebody is accepted into a clinical trial, if there's any funding for travel or hotels?
That is depends on, every trial is different. And when what's really nice is about these clinical trials is there are phone numbers and emails for the coordinators, and you can reach out to them directly and get a lot of information by phone before you even consider entering it or knowing if you're eligible. So those kinds of things they would talk to you about. You could email them, or their phone number is usually listed.
Perfect.
And I know that's very important, because a trial may be half across the country from you, and it's very important to know, well, how is this even practical for me? So I think that's an important question to ask.
Absolutely. Somebody else in the chat wanted to know if I hope I'm saying this right, hereditary spastic paraplegia SPG7, is it the same as FA?
It is not. So hereditary spastic paraparesis has, and I don't know that specific type or the specific gene with that type, but there are several genes associated with HSP. So Friedreich ataxia has some similar features. Sometimes hereditary spastic paraparesis can have a pes cavus foot deformity. You can have spasticity, but what's different is hereditary spastic paraparesis is a different gene than the Friedreich ataxia gene and the triplet repeat, which affects its protein product. So if it is not affecting the frataxin gene, it would not be the same as Friedreich ataxia. It may share some similar symptoms, but it is not the same.
Great, thank you. Another question, how is Friedreich ataxia managed in children versus adults? Are there differences?
Yeah, that's a really good point. And that's why, partly this talk was so broad. It's like, oh, some of this doesn't apply to me, or a lot does and not to someone else. But in children, I had been seeing I see children. I'm a pediatric neurologist, and when we're first diagnosing, we're talking to people about how their life will look later. And but for adults, you kind of know, okay, these are the things that I know are my symptoms, and you kind of are able to conceptualize it, how that might affect your day and how you have to adjust things. For children, it's a little different. Now, for one thing, the treatment omaveloxolone, I don't think is approved for people under 18. So that's one thing that's different. They may not have a medicine available yet. We'll see if something is available for younger children. But they are children are noticing symptoms, but have not started a decline. And that can be a very big impact from a psychosocial standpoint. As you can imagine, they're starting to separate from their peers and figure out new things that maybe they were really into sports, but they also have this other interest, and now they're going to move into this other interest because now they are changing in what they feel comfortable doing. So that's one thing. We are monitoring children. Obviously, the cardiac disease is typically not early on. That becomes later in their teens. So some of the things we're just monitoring without treating, and adults are actually getting treatment for things like diabetes, like cardiomyopathy, like cardiac arrhythmias, and needing more accommodations for mobility and to continue doing things they like to do, like drive and be independent. So children, it's a little different environment being in their own home, but we are watching, how they're doing in school. How can we accommodate to make sure they're keeping up with their peers and doing things they enjoy and are developmentally appropriate, but safely. So same general monitoring. Just a little different stage of their progressive neurologic disorder.
Great, thank you. I was wondering, do you want to take some time to share your slide about your patient perspective?
Sure, let me go ahead and do that, just because I just think the patient perspective is way more valuable than anything I have to say. But I thought these were some interesting things, and I was so grateful. I'm sorry, I'm not doing, for some reason, my little I can't, let me see if I can't get this mouse to behave. So am I sharing my screen yet?
I do not see a screen share right now.
Okay, let me, wait, no. That's all my bad. Sorry, I think I was just off in a tangent there. So is this it? This is it. Okay. Okay. Okay, so I'm going to go forward almost to my last slide. And so this is a young man I took care of from diagnosis on. And we talked about, just what are some thoughts? And, I said, would it have been helpful? And perhaps it would have been good to know someone with a similar perspective and diagnosis. When you're young, you don't always want to hear um, from other people. So, some of these things were like, I just wasn't ready to hear some of that stuff that we were talking about in clinic, which makes sense. I'm an adult and I don't want to talk about when I'm 90, all the time. It doesn't seem relevant. At certain times, certain things don't seem relevant. So I think it's just, you have to understand where people are coming from. Um, for this young person, wanting a purpose and a job is something that is a big desire within them. And they really wanted people to know, there's like workforce resources, there's part time jobs that are office jobs, do things that feel like you are capable of physically doing that because it helps build your resume. And that would have been something he kind of wished he had pursued um, because that would have given that experience in the work world and kind of opened up some doors for jobs later. Um, this person was also saying, there are resources available as symptoms progress. Use those resources. If you have a disability office at a school, at a college, wherever, sign up with them. They do have jobs that are things you can do. You feel like maybe things you won't have opportunities, but there is this workforce recruitment program through the federal government for people with disabilities. And so there are ways to register when you feel comfortable doing that. One of their best memories was being in summer school and college and living independently. That was just a great memory they shared. And then one of the worst things was just that diagnosis. Probably the worst thing was knowing that sports wouldn't be able to be continued. However, the team and people in the community need to know this, allowed the person to continue to participate. Now, this person also had a deep interest in being an engineer, always wanted to do that. So they were quickly able to change into that. So it's important to know what is all the interests of the person, because you can switch your interest into that and pursue other things that seem more things you can comfortably do. Um, I think this is just true for all of us. It's nice to know what you can and can't do, but still, you don't always think about the fact that FA is progressive. So, all of us want to live in the moment now. We don't want to think about the progressive nature of things. Even our own, everyone is, only has so much time in life. Nobody's promised forever. So I think that's the same in people with Friedreich ataxia. They don't always want to think about the decline, and that's okay. We have to meet people where they are and just be ready with resources when people are ready for them.
Great.
So I'll
Thank you
stop
so
sharing.
much for sharing that. All right, since we already did Q&A, if everyone could just hang on with me for just a little bit while I finish off here, I'll give you a little bit more information about MDA and upcoming programs. All righty, so we would again like to thank Dr. Caron for sharing your time today and your expertise. For all those who participated today, we do want to hear from you. What did you like about this program? What can we do differently in the future? Please fill out the brief survey that will pop up right after the webinar, because your feedback is important to us. If you have any questions or are looking for support or resources, please contact MDA's Resource Center. You can call them at 1-833-275-6321, or you can email them at resourcecenter@mdausa.org. And before we go, I want to highlight some upcoming MDA community education events that you might be interested in. You can learn more about these events by visiting our website, scanning the QR code on your screen, or clicking the link in the chat box. First, MDA will be hosting 2 upcoming webinars, including care and planning resources for adults with neuromuscular disease. This will be held tomorrow, January 28th, from 3:30 to 5 p.m. Eastern Time. This webinar will review common work accommodations, explain how to obtain and navigate benefits such as SSI and SSDI, discuss transitioning to a higher level of care as an adult, including home health care, long-term care, and skilled nursing. Next, MDA is hosting a webinar on MDA's impact on neuromuscular research. This presentation will explain the impact of MDA-funded research on patient care and treatment advances and educate the audience on MDA's role in advancing neuromuscular research. You can always click the link in the chat to sign up, or you can contact the MDA Resource Center. Last but not least, we again invite you to join the MDA community. Joining is free and will help keep you up to date on our latest programs as well as the latest research. Please scan the QR code with your smartphone or visit the link in the chat. If anyone has questions, again, you can contact the MDA Resource Center. But thank you to Dr. Caron for speaking today, and this concludes today's webinar, and we hope to see you all again soon.
Thank you very much for your time.